topic of the first panel discussion is Policies that Drive Nutrition. This panel seeks to understand how the ongoing policies aid in improving the nutrition goals, whether there is a need to review them with a different lens, especially when there are new developments and our needs are changing with time. We have the privilege of having representatives, senior representatives from the state government and leading NGOs and researchers working in this space. This session will be moderated by Dr. Purnima Menon. May I please request Dr. Menon to come on stage. Dr. Purnima Menon is a senior research fellow in IFPRI's Poverty, Health and Nutrition Division. She holds an MSc in Nutrition from the University of Delhi and PhD in International Nutrition from Cornell University. Earlier, Dr. Menon worked as research associate in the Division of Nutritional Sciences at the Cornell University. She has been widely published in various reputed international journals. We'll now begin with the panelists. I must mention that today morning, Mr. Alok Kumar of Niti Aayog, who was expected to be here, while almost getting ready and going to the airport, he received a call to stay back for some important meeting. So he couldn't make it to the event today. Shri Kuldeep Ranka. May I please request Mr. Ranka to come on stage? Shri Kuldeep Ranka is an IAS officer from the 1994 batch Rajasthan cadre. In his current role, he is the Secretary, Department of Women and Child Development, Government of Rajasthan. He holds a BTech in Computer Science. In his previous roles, he was the Managing Director of Metro Rail Corporation, Commissioner, Jaipur Development Authority, and Rajasthan State Industrial Development and Investment Corporation, Chairman, Discoms, etc. Shri Naveen Jain. So I would again request you to come on stage. Shri Naveen Jain is an IAS officer of the 2001 batch. He is the Mission Director of National Health Mission, Rajasthan. He holds a BCom Honours degree in Business Finance and Masters in Finance and Control. He also holds a diploma in Public Policy from IFPRI University. In his current role, he has led one of the largest pilot of community-based management of acute malnutrition with astounding results. Asha Soft, E-Subhalakshmi, Kuposhan Watch, a software for malnutrition treatment center, E-Upkaran, which is an equipment management and maintenance system, are some of his achievements, among others. Mr. Tarun Vij. May I please request Mr. Vij to come on stage? Mr. Tarun Vij has been the country director for GAIN, which is Global Alliance for Improved Nutrition, India, since September 2015. He holds a BE in electrical engineering and an MBA and transitioned from the private sector to the development sector in 2005. Prior to GAIN, he led PATH in India as country program leader, served as country director of American India Foundation, and was a project director at TCI Foundation and implementing partner of Avahan. Dr. Prasanta Tripathy. May I please request Dr. Tripathy to come on stage? Dr. Prasanta Tripathy is a co-founder of Ekjut, Honorary Senior Research Fellow of Institute for Global Health, University College of London, and member of Mission Steering Group, MSG, of National Health Mission. Ekjut is a recipient of WHO Public Health Champion Award in 2015, was a recipient. A medical doctor by training, Dr. Tripathy works with indigenous people of Jharkhand and Odisha. Ekjut partners with local communities for evidence-based work on saving maternal and newborn lives, combating undernutrition, addressing inequities, publishing findings in high-impact journals, supporting replication of PLA, which is Participatory Learning and Action Approaches and Influencing Public Health Discourse. Dr. Tripathy is a lead, which is Leader for Environment and Development, and an Ashoka Fellow too. Over to you, Dr. Menon.
Thank you all so much for having me here. I've been hearing a lot about the exciting developments around nutrition in Rajasthan, and had the pleasure of spending 5 days with Mr. Jain in the short course on nutrition that Lawrence Haddad and I co-teach in the UK, and was hearing quite a lot about the CMAM pilot and just the growing interest in work in nutrition here. So it's just really fantastic to be here. I've been personally looking at the data from Rajasthan and from many other states, and I'm really quite impressed with how there have been several improvements in the last decade or so in terms of coverage of key interventions and some of the other drivers in nutrition. It's a tremendous opportunity, I think, for people to come together now and look at, really how to come together and act together to really change and accelerate the diverse aspects of nutrition. So not just stunting, but also anemia and low birth weight and wasting. And there are several examples and experts in the room and on this panel, I think, who can speak to different topics related to that. So I think what we're going to do is, I do have a set of questions for each of you. And so what we're going to do is that I will actually pose some not so difficult questions, I hope, to each of the panelists here. And then I think because we have a little bit less time than I think we started off with, so I think we need to go to about 4:15. So we'll, after one round of questions, maybe open it up for some audience questions to each of you as well. So we're going to start with Mr. Kuldeep Ranka. So I understand that you have said earlier that policies and related to nutrition are institution-centric, and that you've been raising issues about them needing to be demand-centric. So I'm wondering if we can hear a little bit more from you on what that means, and then if you have any thoughts on actually how to get to being demand-centric. So over to you.
Thank you, Purnima ji. First of all, I must congratulate Naveen for having given us very valuable insights into CMAM program. He has been driving this program for last 2 years and has been working very hard in the field and also at the state headquarters. Now, coming to the issue of institution-centric policies, we all are aware in Government of India had launched the program of integrated child development services about 4 decades ago. The approach was to bring the beneficiary population to the ICDS centers. Even in the context of treatment of SAM children or treatment of other targeted group, it is basically broadly an institution-driven approach where the beneficiaries are brought to the institution and then the medical treatment is taken care of. Now, we have been seeing in last 4 decades that there has been marginal improvement in terms of percentage population under malnourishment. However, still India accounts for 30% of the world's malnourished population. And why we, despite spending so much of funds on this activity and despite having 4-decade-long program, not being able to overcome this issue. There are a large number of challenges, social, economic, others. But one major finding which we can see, if we look at the basic unit, that is the Anganwadi center at the village level, the expansion in terms of number of Anganwadi centers has happened all over the country. Now it's within the reach of the community. They normally need to move about 300 meters to 600 meters to reach the Anganwadi center. However, even today we find that beneficiary doesn't reach the Anganwadi center. Even today we find that when we go to a Anganwadi center on a random basis, Naveen would support me, we often find 10 to 20 children 20 is something ideal, and in fact, we are driving a campaign for last 3 months through our WhatsApp groups and also through other monitoring mechanisms, motivating each of the Anganwadi workers and the lady supervisors to touch the target of 20 at each of the Anganwadi centers. So it is true that we have not been able to get the beneficiaries, large proportion of the beneficiaries to the Anganwadi centers. It's an institution-led approach because we have a formal institution where the worker, the Anganwadi worker, the helper, and other associated community members reach out there. They try to find the ways to feed the malnourished children. Now, if we were to actually cover the whole population and look into lactating women, pregnant women, adolescent girls, and children from 0 to 6 years age group, how do we make it demand-centric that they on their own come to these institutions? They take the benefit of ICDS mission, and what could be the factors which will drive the demand? This is something we all need to, I think about. Some of the reasons could be in our society as a social trend. You know, wherever the food is being given free of cost, services are being offered free of cost. If it is something related to the government program, the upward trend, it's not very fashionable. It's not something which people try and do it on their own. So that could be one reason why a part of the society may not find it very attractive for them to go to the institutions. Initially, it could have also been the access was limited. It was not in the pockets of, say, underprivileged groups of the society. But now that challenge has been sorted out. There are problems of physical infrastructure. We have buildings sometimes which are running in the rented accommodation. Sometimes they are just one room accommodation. There are no separate facilities for toilet or drinking water. So there are challenges of physical infrastructure, and the children may not find it very attractive being there. Then, 4 hours program at the Anganwadi center, talking about feeding, the worker not being able to come regularly, the schedule of program of the 4 hours not being very interesting to children. That is another issue. And how do we improve the capacity of the worker who is handling that? How do we ensure their presence? The most basic issue, how to get the Anganwadis open on time and maintain regularity, that is a challenge. So I do not have experience like Naveen of working in a district like Bara, but we relied on our administrative experience and thought that when nothing works, perhaps to make some of the common things happen, we would need to resort to our age-old practice of administration. And therefore, we started the massive drive about 4 months back in July of physical inspections of Anganwadis. And I'm happy to inform you, 98,000 inspections have been carried out in last 3 months. And there will be weekly inspections. And now we hear in the villages, the public representatives come and tell us, our officers tell us that things have changed drastically. Now there is no complaint of Anganwadi not opening on time. This is a challenge everywhere. And they are not the highly paid government servants. They are honorarium workers. They are part-time workers. Their skill levels, education levels are not that good. So looking to all that, how to ensure that their presence is there, this was a big challenge, and we did try to stabilize it, but we need to find sustainable solutions. Technology could be one such solution for ensuring that Anganwadi centers open. Because this itself becomes so demotivating for many of the beneficiaries not coming to Anganwadi. If it is not opening regularly, if there are no regular activities, if the worker or the helper is not available there, then it itself becomes so much of frustrating for those children to come to those Anganwadi centers. So the solution is in technology. We are thinking through the World Bank assisted project of SNP, where the biometric attendance of the Anganwadi workers, helpers would be ensured. As on date, we are doing through different methods. We have used the WhatsApp, and the lady supervisor goes every day in her sector, uploads the photographs, and we have used the uh, app from the Google Play Store, that is Open Data Kit. We have customized that pre-populated data, so all our LS and other officers are going there, and it is geo-tagged. So when they feed the data from there, it's real-time data. So at least we come to know that physical inspection is happening, and that has brought a lot of improvement. So this is one other aspect why demand-driven institutional approach is required, apart from just giving supply, creating infrastructure, posting the manpower, and trying to get the best out of them. We also need to create demand in the citizens. These are supply side measures. Creating demand would require a whole lot of new interventions. Could be through campaigns like involvement of community. So we launched a campaign about 4 months back that's called Anganwadi Chalo Abhiyan. So instead of focusing that everyone like in his school should get enrolled in Anganwadi centers, we focused on involvement of community by providing support in terms of improvement of Anganwadi center. It could be in the soft activities, it could be in terms of physical infrastructure, it could be in terms of providing uniforms to the students, uniforms to the children, so that they feel the pride of being in the preschool at the Anganwadi centers, or it could be in the form of providing toys to make the stay there more meaningful, more enjoyable for them. It could be in the form of revised curriculum, syllabi. So we have worked on those interventions, and we realized that unless the community is taken on board, the family members take it seriously and they bring their children there, it is difficult to have on sustainable basis even 50-60% of intended beneficiaries at the Anganwadi center. So it's a challenge. I think I would like to hear more from all of you, how we can make it more meaningful and make it demand centric. Thank you.
Great, thank you. Really fantastic remarks there. I actually had no idea about the inspections, and it's remarkable to hear about that. So I'll maybe come back to you with a couple of follow-up questions later on. But I just want to move to Naveen ji. I think it's been remarkable. I think we've heard about the CMAM pilot work in Rajasthan. I had the privilege of hearing quite a bit about it when you were in the UK, but also you spoke about it here. You've managed to now implement this pilot for a large number of children in a large number of districts, and I'm wondering if I have two related questions for you. So one is, what are your thoughts on the policy side of this? And it could be Government of India or it could be state policy. So if you could just comment on, has there now been enough of implementation experience to inform a new direction for policy? So that's one question. And the second question won't come as a surprise to you. As you know, the treatment of severe acute malnutrition, severely malnourished children is sort of the last resort. These are the children that have been missed for many, many, many reasons in a policy and programming environment that actually offers a lot of preventive services, whether it's through antenatal care to women or through services at the Anganwadi. So I'm wondering if you can comment a little bit on building that connect a little more strongly with prevention. So two questions to you, and maybe just a few minutes.
First of all, you talked about that CMAM thing we did, and the policies which may come into place now to how to take it forward actually. So I think pilots are just to try, just to experiment things, and pilots in sufficient quantity are also required, because we tried with 10,000 children. I said it in my address that sometimes we implement certain things in some villages, in some blocks, and then we wonder how the replication is not happening. What I believe, I'm not talking adverse against pilots, but what I have felt, when we start some pilots, we take some area which is marked, which is earmarked, and then we hire people at district level and block level, even to village level. And then suppose we are watching maybe 20 people, and maybe there may be a team of 10 people who are watching them. And naturally, after 6 months or 1 year, whatever is the period of the pilot, we see results and we think that now it can be done. We forget that when we will replicate it on mass level, maybe in half of the districts or maybe in the entire state, the pilots will not have that team in place, which was there when it was a pilot. So we have to think, whenever we start something, I think we should take care of what we will be able to replicate. So development partners or the people who make the concepts of pilot, they should see how the total thing will be replaced when it will be taken over by the government. In my case, suppose we want to carry along with CMAM. I think still we will have to do some more pilots because we have been able to take 13 districts. We have to try it in certain other districts where we have not been able to go. Even some of the divisions we have not been able to touch. So, but after 1 or 2 pilots, we have to come to a policy that, how it will be placed. Some of the states have adopted a philosophy, or maybe one of the easiest way is of making a state nutrition mission. And many times, we have been said, why don't you make a state nutrition mission? What I see, I don't want to comment how they have been faring, but I think making a state nutrition mission is the easiest low-hanging fruit which we can get. But does it solve the problem? And I think the biggest problem with CMAM has been, right now many states are discussing about it, and the common problem which comes out is that whether it will be led by ICDS or whether it will be led by Medical and Health Department, and what will be the role of NHM in the entire picture. So I think somewhere state can also make their own policies, nobody stops them, but I think if we can come on a national policy of CMAM, how things will be placed between NHM and between ICDS. Both get funds from Government of India. Now, Government of India can always decide, how they will give it, whether they will get it through ICDS, NHM, or they will make a third mission or maybe third thing to carry it out. But a policy has to be made at a national level so that there is a uniformity. And when you need certain things, you can bargain. If you do it at a large scale, then we can make them through big foundations, big federations like AMUL, so that procurement issues which have, hampered sometimes in some states will not happen. And as far as second question is concerned, the connect which we need, actually prevention part is important. CMAM and MTC happen when, when you have lost the battle and some children are out of it. But naturally there is a process. When there is a pregnant woman, if we don't take care and there are certain issues, we do not take care of her high-risk pregnancy status, we do not provide her IFA or maybe iron sucrose, or maybe we are not taking care of the immunization or certain other things, definitely they can suffer. I would like to focus on one thing, that is MCHN Day. It is called VHN Day in some states. In Rajasthan, we call it MCHN Day. Now, the full form of MCHN is maternal, child, and nutrition. And I think, if we see, I think nutrition angle has been totally ignored. ANMs are supposed to go in the morning, and whatever women and children have come, they have to take care of them. It was a fantastic concept. And Rajasthan was one of those states where MCHN days were institutionalized quite well. Still they are institutionalized. But now when we go to the field and when we get the feedback, we are finding that ANM is going very late. If she is going, she is not taking her equipments along. So there is no BP, there is no sugar test, or there is no urine albumin test. So whatever is happening, it is all superficial. Actually, they should identify the high-risk pregnant women out of them. They should also work on finding the SAM children, maybe SAM with complication or without complication. So I think we don't need a policy on MCHN Day because MCHN Day is already there. Yeah. I think it is more of an implementation issue. We, two departments, need to see why we are not able to implement a wonderful concept like MCHN Day. So nutrition angle, I think, has been totally ignored from the day. ASHA was supposed to go one day prior to the MCHN Day in the village to find out the beneficiaries, make a due list, and to ask the people to come. And I think if we can implement it very well, I think many gaps can be filled.
That's great. So I think we have an implementation challenge and a next step for the two of you collectively to take forward, possibly. So I'm going to turn now to Tarun, and it was really amazing to hear your introduction and sort of appreciate the variety of experiences you've had in multiple sort of roles that you've played trying to support different government programs and efforts to improve different areas of health. So I'm wondering if you can actually reflect a little bit on that and speak about the role that NGOs, development partners that are interested in supporting policy issues in certain areas can play. And I know that in your current role you're working on fortifications. If you'd like to reflect on this set of issues of the role of these multiple partners in supporting government with that example, I'm more than happy to have you do that. But I know you've had other experiences as well, so please.
Thanks, Purnima. I think in the context of India and the development space, one thing is very clear. We are a very complex country. There are contrasts across our landscape. We have amazing examples of successes in a variety of human development indicators in certain states. Within the same state, you will find certain districts are very backward and certain districts are doing very well. And then when you extrapolate across states, within regions, you find so many variations. So I think one of the things that I learned very quickly, to my humility, was that India does not lend itself to very standard solutions. So we are an evolving country and we are learning so many things as we go along. That is one. Second, I think what I see in the last few years in India, and I would say last few years, perhaps the last decade, India is saying a couple of things. One, India is saying there is enough evidence available and then there is enough suffering and enough work to be done that let's start building upon the pilots. Pilots are not going to be enough. There are not enough passengers. Let's start scaling up. Let's look at approaches that are strategic, that lend themselves to large scale. And I think we have seen a very, very increasing appetite of government to partner with development partners. It's no longer that, you guys don't understand how government works, we will work by diktat, etc. No, I think there is an understanding within government also that the job is not going to be done in a very unilateral way. Let's do some smart partnering. Let's bring, and I love the Antara Foundation, this one, let's bring more people in the tent. You will need public health experts, you will need corporates, you will need government, you probably will need media, you will need a few activists also to course correct everybody. So I think that's the other thing that I say, move away from pilots and let's look at smart partnering. Let's build hard to build complex alliances if we really truly want to get our elbows dirty and achieve impact. The other trend that I see is, at least at the national level, a lot of synergies within government departments. I see a lot more conversation between government and government. So whether it is women and child development and health and family welfare, whether it is food and public distribution and the education department, seems to be a very purposeful convergence. There is discussion, people meet, people talk, people develop policies. So one does hope, like Mr. Ranka and Naveen ji were saying, that a lot of this convergence also starts happening in a very purposeful way in the states. Yeah. It is tough to do, but I think that is what, and let me just come back to, NGOs. I think NGOs, have to understand that the only impactful work will happen if you are in partnership and not building something in a separate silo from government. That's one. B, there is enough global best practice, enough global evidence available. So whether it's guideline implementation approaches, safety efficacy data, there is a lot that NGOs can bring to the table, but that needs to be adapted from a global to a local context. And obviously, wherever there are gaps, NGOs can step in and fill in any evidence gap. required. But I think the need of the hour is how do you smartly partner with government for large-scale implementation?
Thank you. Really thoughtful remarks there. So I'm going to move to Prasanta ji, who is a fellow researcher like myself. I have tremendous respect for your work, which is so grounded in helping communities help themselves at the end of the day and demonstrating that through research. And you've been really so actively involved in that kind of implementation research that's around, ground up work, connecting communities to services, to issues, and to working on the issues with their own strength as well. But your research has also actively made it into policy, especially in states like Odisha. So I'm wondering if you can tell us a little bit about your experience with taking lessons from research to policy, doing research that's meaningful to policy, and shed some light on how that has unfolded in your experiences. I'm sure there are more researchers in this room than just you and me who'd be interested in hearing about that, and certainly our policy colleagues would also be interested in expanding and deepening that conversation.
May sound like a discordant, discordant note, but conversations are also happening in the community level, and but a structured design had to be provided. I'm talking about participatory learning and action, where groups of women come together every month. Month after month, I did not know that they will continue to meet year after year. So these meetings had to be made interesting. We spent so much time trying to make these meetings interesting that in the first year of a trial, nothing changed because we were only collecting story, interactive games. So we had to do a little bit of studying also. At the end of 3 years, in 200 villages, just women meeting once every month, neonatal mortality between 2005 to 2008 fell astounding reduction in neonatal mortality during the year 2 and 3, 45% reduction. And there was a huge traction from media, starting from Time magazine to BBC to almost all different languages in India, E-Nadu, an editorial in Odia newspaper. But public health colleagues were not impressed because this was challenging something that all of us are used to. Because in health meant, the building blocks of health meant staff, system, stuff, like equipments, etc., space. I think what was amiss was community empowerment. It was necessary in certain parts of India because the outlook of people could be explained in just one word, fatalism. What has to happen will happen, predeterminism. Bachche ko to marna hi, kind of situation. That kind of a situation, to dispel fatalism, participatory learning and action, I'm not going to discuss detail about this method. Just meeting once every month, just imagine. Something interesting was happening. Then we looked at, so this was published in the Lancet in 2010. In 2011, Society for Clinical Trial selected it as the best research published in the year 2010. So we had not applied for any award. Something fantastic was happening. And then we were challenged. Try this in control area and show us what happens. And we found mortality fell in the first year itself because there was so much of learning. And we looked at our data seasonality wise. And we found that most of the babies were dying in the winter months. And there was hardly any mention in public health literature about these winter deaths. Of course, we know about hypothermia. So something extra had to be done during the winter months. Rajasthan will be very similar in that situation. A huge number of deaths can be reduced. The babies need to survive first for them to become healthy. We looked at our data through an equity lens and we found that the poorest benefited the most. So definitely, these meetings were attracting like magnets for the poorest. Interestingly, we knew that this cannot reduce undernutrition. Obviously, we are not naive to believe just one meeting every month will reduce malnutrition. We added one more component of home visits and counseling because government was interested in first 1,000 days. Can we have one more worker, Suposhan Karyakarta, focuses on first 1,000 days, visits homes, etc. And this is caring trial, the results of which will be published in the month of January. And I can share some findings, but my colleagues will be very angry with me. But mortality fell and malnutrition also reduced. I won't give up everything right now, but some amazing results you will see in the month of January with Suposhan Karyakartas visiting homes of kids below 2 years of age and conducting 1 or 2 monthly meetings. We have looked at dietary diversity. We have looked at certain parts women also drink during pregnancy if alcohol consumption comes down. Has it made any difference in spacing between kids? BMI will be too much, but we did look at their height and weight when they were 9-month baby was born. And hygienic practices improved like anything. Why this one is particularly interesting is the methods that are being promoted in India to improve hygiene is very insulting to the communities, and it's always naming and shaming. Here a lot of things are discussed respectfully and you will see huge improvements in hygiene. So in between the first 1 or 2 trials, when I went to government, the best response I got was from the bureaucrats, not from academics, let me tell you. Every time I showed my data, they would ask for my laptop and they said, "Kal se hum shuru kar dete hain." Because they had seen in districts that something like this is working during their visits, etc. A little bit of tweaking is required. So everywhere we got response. It was very easy actually for scaling up. In Odisha, Aarti Ahuja got interested. In Bihar, Gram Varta came. In Madhya Pradesh, Sanji Sehat came. There was a time when we were working in 50,000, 60,000 villages, small organization, 60,000 villages, 10% villages of India. So it was possible because of the magic of participatory learning and action. And last year, central government, we never oversold this. We always said, please try this in your underserved areas. But then somebody told me it will work in even better of places because if the death among the poorest quintile is coming down, then it will work everywhere because there will be always some kids who will be from the poorest families. So where even the NMR is below 30, it will work. So last year there was a circular for scaling up, set up in 10 states. In the meantime, I should not take more time of the conversation. World Health Organization accepted it as, recommended it for global scaling up in other countries. So my experience is if there is robust data and the quality of data is good, and we invite people when the research is happening so that people could come and see that the quality of data is good. We don't focus on just a few villages. Even a randomized controlled trial can be done like an effectiveness study like sir was explaining. We selected large 20,000 square kilometer was selected for the first trial. Second trial where we involved ASHAs to conduct these meetings. ASHA started conducting one extra meeting and mortality fell by 30%, in addition to all our work. So it's possible to influence governance from the perspective of the poor if something is working. And so government is very keen to look at evidences that work. That has been my experience.
Great. Thank you so much. I think the experience of the PLA trials for multiple maternal, newborn, and child health outcomes in India has been really tremendous. And, you know, certainly as a researcher, I think that having some of that work published and demonstrated in top, really top journals has only helped the case for scaling up and expanding that work. And it's been this great combination. So, you know, we take a lot of lessons from that as do the research well, do the interventions well, and the results are there to see. And of course, policymakers we know are interested in things that can move quickly. So what we've heard so far on the panel has been, Mr. Ranka, your, you know, really, I think, honest admissions, if you will, of the challenges with getting the community in to access services, of getting service providers to do the basics, open the door, show up to work, be there if the community wants it. And really those are real fundamentals in changing the institution so that the community itself comes. And we need to learn a lot more about how to really bring them in and how to strengthen quality of services. Naveenji, you made some really great points about the connections to preventive work and of course, you know, the need for national policy guidance also to be available around CMAM. I think, you know, we will pose the challenge to the two of you. I think it's, again, you know, I do want to say as Tarun did, it's fantastic to see health and WCD who provide such important services for nutrition on the same stage, and we are seeing this more and more and more at the state level, at the national level, and personally I see that as a great sign. You of course spoke, Tarun, about the importance to work in partnership with government and to use the power of NGOs that have connections sometimes to other places and have experiences and, you know, knowledge about things that are happening in different places to bring those quickly to the areas that we're all working in and being interested in. I'm not going to even try and summarize, Prasanta ji, what you've been saying about your work, because I want to give an opportunity to people in the room to ask questions of the panel. Feel free, I think there must be mics available in the back of the room or people sending mics around. If I could get a show of hands for people who would like to either make a comment or ask a question, that would be great. And then maybe we'll do 3 or 4 questions or comments to start with and see how we go. We have about 15, 20 minutes. We're expanding the tent, so we need people in the tent to speak. Yes.
I think I'm in the tent very much, but I couldn't resist asking the question of Kuldeep ji and Prasanta ji. In a way, you're probably both saying the same thing, but it sounds like, Kuldeep ji, you're talking about the challenges of getting the demand side involved, the community side involved, and having forced to respond more on the supply side than you would like. And Prasanta ji, it sounds like you're saying getting the demand side and the community going is fairly easy if only people did it. Perhaps I misunderstood you, or perhaps you can just, both of you or one of you, comment on this so I can understand this better.
Great. Let's get 2 more questions. Maybe in the back. Please do identify yourselves as well.
Hi, good afternoon everyone. I'm Ritika from Digital Green, and so I would like to first share one of our researches, which is actually we're doing in Orissa with Ekjut and IFPRI, and it's actually we are doing a very detailed sort of, and it's still going on right now. So it's about this entire, we are comparing in a control and in the randomized control situation the impact of nutrition sensitive vis-a-vis nutrition specific sort of communication. So I'm sure when we have the results, we will obviously share with all of you. But that actually brings me to a bigger question, which I want to pose to the panelists, that how do you think that, to bring about demand driven, to drive demand in this space, like what do you see is the role of risk perception that we need to create around malnutrition among the community, and do you think messaging, the role of messaging, like how do you see that in the space of nutrition? Thank you.
Great question. Is there any? Okay, one more hand. 2. Okay, we'll take those 2 and then maybe come back if there's time. Yeah.
Thank you so much. Good afternoon. My name is Sam. I'm with UNICEF here in Rajasthan. Just want to find out from the panelists, if we were to go for this global approach of 1,000 days and institutionalize it, especially within the government, do you find there is a space for the government departments to come together? Because the performance indicators are on the 1,000 days. It's not only individual, and they are actually becoming more collaborative in delivering the results of that child of this life stage. Do you see this as one of the possibilities as a policy guideline for implementation?
Great question. We'll take the last question on this side of the room. Sunita, can you get a mic over here, please? No, yeah, thanks.
Good afternoon, my name is Sunita Singh, I'm from Amantash. I'm going to pose a slightly provocative comment to Mr. Ranka and Mr. Jain. Having now watched public policy making and implementation over many years in India and at state level, one of the things that I find is that often there's a lot of stepping on toes between departments. So if you look at what is the primary purpose of the health department, it is to provide preventive and curative care, but I might make the provocative comment that it is in fact this preventive and curative care that people should be seeking. Whereas if you look at what it is that the WCD department is supposed to do, it's sort of a more outreach, it's sort of more along the Ekjut approach, etc. But we find that very often the government, perhaps in pursuance of the War Committee of 1946, sort of steps out and keeps trying to reach people, and the Asha approach is one of those efforts. On the other hand, WCD in its effort to provide comprehensive care is, talking about kits and this and that and the other. I'm wondering how much these two departments are changing their mindsets based on the modernization that we see in the country, even at rural levels. So it isn't just that, urban India is modernizing, but rural India is modernizing in a very real kind of way. And I wonder how much policy is actually taking that into account and therefore making collaboration that much more effective.
Big question. So why don't we take that as the last question, and then I will hand it back to the panel, because I don't think we're going to have time for a second round of questions. So you get the last question, sir. Please identify yourself.
Yeah, I'm Vijay Shekhawat from Evidence Action. My question is from Naveen, sir. You have mentioned about CMAM programs and related community engagement experiences. And you also mentioned about the need for some more pilots on this issue. My question is that based on your current learning, how you are going to incorporate these learning in policy making in the long run?
Great. So one big question was on communities and your frustrations from a supply side and your experiences from a community mobilization side. So if the two of you could address that, that would be great. And then we can move to the other questions.
When so many people are asked, you forget that which was the first question, so I will try to respond to that one. No, it's not that easy. The careful preparation doesn't show. There's a lot of hard work goes on behind the scene. A lot of time is spent in designing these, and sometimes it goes wrong. Then you come back to the drawing board, and at the same time you are working on many other designs. For example, how do you use this method to curb violence against women, for example, or how to make things interesting for adolescents? They are not going to listen to lectures. So should we give them goods transfer? If you achieve something, then you get sports items, for example, or items for cultural things. I'll stop there. There was another question about risk perception. These are meetings happening every month. One meeting flows to the other one. There's an element of surprise, etc. Once in a while, risks do get discussed, but there is more discussion about, the malnutrition. We did not know how to discuss about it, but finally, right now what we have zeroed in, and later on it might change. बच्चे चालाक होंगे, that's what they want. The kids, it doesn't matter, थोड़ा बच्चा लंबा हो गया, 3 millimeter. So that was a question about to digital green colleague. maybe we'll take a couple of...
But can I just ask you to speak a little bit more to Ashok's question, which is...
Which was Ashok's question?
You've said that it's difficult to create demand for better nutrition in a sense, but your experiences suggest that it's not so difficult if you put your mind to it. And so the question is to respond to that. Was that okay to paraphrase
I think
your
sir
question?
mentioned it, he was talking about specifically about attendance in Anganwadis. So we have small experience, so I should not be giving advice to government. But we run creches in 60 places in most underserved areas, and I will, if you give me a chance, I should be able to come and make another presentation. But a lot can be done around early childhood stimulation and preparing local toys, materials, etc. And also, you know, roping in other people like friends of Anganwadi, etc. But a lot of engineering work is also required. For example, in the room in which cooking is happening, so smokeless chulha is a must, because we have looked at our cross-sectional data and found the biggest predictor of height was whether the cooking is happening outside the house. Cooking inside means 0.4 standard deviation difference in undernutrition.
That's huge.
So, something needs to be done related to light, and it can be easily done with tiled roofs, putting a little bit of transparent thing. So I think we were running 60, so I should not be giving any advice, but definitely a lot of work on making things playful might help, I think.
Thank you. Would you like to respond to that?
No, I fully agree. In fact, in my opening remarks, I had mentioned that while we are making supply-side interventions in terms of providing an environment where the children could stay, not only come to the institution, but also stay for whole duration of the day. But I believe, as Sokji had asked about and Ritika ji had mentioned, the solution lies in communication. Know how effectively communicate the risk associated with malnutrition to the society in general and to the targeted population in specific terms, what exactly needs to be done and what could be the outcomes if they are not reaching out to the Anganwadis. That is one way of creating demand. The communication is the oldest technology and perhaps since the human civilization, and that is the only way to know what are the demands of the community and what are the need assessments done by the supply side interventions. So if that communication two-way dialogue starts in a meaningful way, now arranging a dialogue with such a vast section of society in a structured way is always a challenge. There are studies, there are methods which we often see in the public domain, which is available to us not only in the nutrition sector, in other sectors as well. But translating those models into action on such a large scale is a vast challenge, and that's where the regular training of the workers, regular communication with the community, and then doing action with the community by home visits, by other methods is required. That's a very daunting task, and I know there are models which are successful, but implementing them would be a really major challenge, not from the policy point of view, but the sheer scale and perhaps the mention which she made of technology. That could be of help. Nowadays we are living in an age of information technology, and perhaps if we make the use of technology today, we may reach out to the larger community and we may be able to communicate what is required for that.
Thank you. So we have a little bit more time, maybe if the organizers would give us about 5 minutes. If you all could address the questions on...
there was one direct question. Hello. Vijay, you asked the question about the learnings which I can carry forward. Actually, we have learned a lot from this CMAM pilot, and the biggest lesson which we have learned is the convergence and coordination issue between Medical and Health Department and ICDS. Many conferences can be held on this issue, how we can converge and how we will not be able to converge. So, you know, but still I will say in every state or in maximum programs, development partners find it really difficult. I'm talking from their point of view. Like, you know, when they come to states, they say that, you know, okay, MD and HM may be interested in talking to Director ICDS, but Director ICDS may not be interested, or vice versa. So, you know, one person when he is in NHM, he may be having some different comments, and when he enters into ICDS, he may have a totally different story. It can happen. I think this is the real story. We may name it anything, and we may talk it about any. So perceptions and personalities, impressions, whatever, we keep on changing. Now, the learnings. We did not involve ICDS department from the beginning. Now, whenever we will take CMM2 or whenever there will be a policy, we will say it cannot be run alone by ICDS and it cannot be run alone by NHM. So this is the biggest learning. The reason is, if you will believe that only ICDS can run it, the biggest difference between two departments is that in ICDS, you have only block level officer called CDPO. Then directly you have some lady supervisors. Normally 50% of the posts are vacant, I think, normally. And then you have Anganwadi workers. So if you want to feed the data from Anganwadi worker into a system, how many feeding windows you have? You have only 250 block windows. But when it comes of medical and health department, you have 2,000 plus PHCs and 500 plus CHCs. So you have 2,600 feeding windows. So because we need to take the data constantly from the field so that we can see where the gaps are taking place. So we have some strengths, they have some strengths. So they have more Anganwadis. They have 61,000 Anganwadis. So again, I will say that AAA platform, we are talking a lot about it, ANM, Anganwadi worker and Ashas. But I think we are talking more when we are less exploring. So if we can explore that in our program, I think we can make better policies. So we have to decide, I can't say in what state, what proportion of leadership or resources should be shared, but definitely this is the biggest thing, how to divide our responsibilities and liabilities, actually.
Sunita, do you think that addressed a little bit your question about stepping on toes?
Certainly a little.
Okay, good.
I think my question is a bit unfair in any case, as Mr. Jain says.
So maybe you can also discuss that at tea time. There was one lingering question on the 1,000 days and whether having an integrative policy that places accountability on services for the 1,000 days would help. And I think it would be good if one of you could speak very briefly to that, so then we can try and close the panel, yeah?
Thank you, Sam, for reminding us about the basic 1,000 days action plan. Ritika also spoke about nutrition-specific and nutrition-sensitive interventions. Ultimately, all this boils down to convergent action on the nutrition aspect. Taking child as an entity, child as an organic entity, and how to ensure that all the actions by different departments converge on child and we are able to monitor them in the initial 1,000 days. So far, this has not been put into practice. There have been discussions, thoughts, as Naveen mentioned. There has been few approaches where the convergence has happened, like MCHN Day, where the health and Anganwadi workers sit together, do the nutrition education, health education, carry out the medical checkup, go for the, suggest for the referral services. But that is a very small part of it. There are also convergent actions happening in terms of preschool education, so that the Anganwadi centers convert from feeding centers to feeding cum knowledge centers. And in a way that answers what Dr. Tripathy has been saying, creating the environment more enjoyable, where the retention of children could be ensured in a better way. So that only the nutrition does not remain the activity and there is something more to it. The 4 hours child sitting there is not there just for the snacks or the hot meal or take-home ration. He is also there for other meaningful activities, and that's the basic nature of child. He can't sit idle. He can't be just staring at the, the room and thinking only about the food. So those convergent actions are also happening. In fact, a large number of Anganwadi institutions are getting shifted to schools. But to be very frank and precise, the other interventions such as drinking water, safe drinking water, providing the toilet facilities, developing the practice for the hygiene within the beneficiaries there, or maybe about creating awareness amongst the self-help groups or the women community or the Panchayati Raj institutions. That's not happening in that focused way. So what Mr. Sam has suggested, if we draw up an action plan for all the relevant departments and bring about transformational change in terms of implementation by each of them, and if there are defined milestones for each of them for the first 1,000 years, so that can help. The approach could be, we could start from PCTS, as Naveen mentioned, that has the data about the birth of every child. So that could be taken up as the initial point, and thereafter each of the department would need to monitor, and we could also have convergent action in terms of meeting regularly, analyzing data, looking at the impact which it is making. So that's a very good suggestion, and we need to really look at it.
Thank you.
One second. The Ritika has asked a very good question. You are asking that, how to create demand for it. Actually, we all seem to be at the supply side and trying to impose things on them, and we are just trying to bring them to our Anganwadis, and they are not interested. So how to do it? I will pose question in answer to your question. Can we take clue from what has happened in full immunization and institutional delivery thing? How we were able to create risk perception around the women and the mothers, because it in last 10 years of NHM, 34% institutional delivery in Rajasthan has gone up to 84%. And the full immunization, which was only 26.5%, has gone up to 74.2%. So what I'm saying, somebody has actually worked on these things. So I think we can take clue from how we were able to build them and can take some clue from there, I think.
That's great. Thank you so much for raising that, because I've also been looking at some of the data on changes across states, and it's remarkable to see how some indicators in terms of coverage of services have changed. There are some where things have gotten worse in terms of iron folic acid consumption during pregnancy, and that's obviously something big to work on. But thank you for raising the positive changes that have happened across. Did you want to make any comment on that, Prasanta?
Yeah, because the discussion is about first 1,000 days. I mentioned to you about a study that we did, and then we went to policymakers. Sometimes policymakers want something for which research should be commissioned. Policymakers wanted to know what role the second Anganwadi worker should have. There was a talk about second Anganwadi workers. I will make a very strong case in just 2 or 3 sentences. That's the reason why we did this caring trial. It was modeled after a second Anganwadi worker when or if she comes. She is focused. We called her Suposhan Karyakarta. And all this convergence will happen if this worker comes. It can start with the recording that you mentioned, birth weight. She focuses on the first 1,000 days, visits the houses of kids up to 2 years of age, and during the pregnancy, 1,000 days covered. You will read the results in the month of January, and hope you will invite me here. You will see the importance of having one more worker in focusing on first 1,000 days. Thank you.
Great, thank you. Any quick closing comments?
Just a couple of comments. One is, the whole community engagement piece around dialogue, and how can we create more spaces for dialogue? Communities don't often appreciate being all the time fed information. So is there a dialogue approach, and are we tapping into the inherent self-esteem of our communities? However educated or uneducated they may be. So that's one side. How can we have more participatory dialogue? Second is the use of lots of people are making the mobile apps and technology and process and building lots of IT platforms and things so that information can flow well. Yes, information will come, data will come, but people will not collaborate. Departments will not collaborate. There has to be a blend of process, structure, but chemistry will always be there. We have to intend to collaborate. We have to intend to partner. It will happen. Otherwise, it will not.
That's great. Thank you. Those are really wonderful. That's a wonderful place to end the panel. I'm definitely being given the signal that we should move on. So I would like to thank all of you. I'd like to thank you all by saying that I've been working on nutrition in India for close to a decade now. I've worked on Bangladesh and Haiti and some other countries before coming back here to work on this. And Dr. Shankar, people like you and me, we started some of these conversations of interventions for the first 1,000 days about 9 years ago. 2007 almost was the first conclave with the leadership of Professor Swaminathan. And actually, to hear some of the words that the two of you have used, especially today, I think are really music to our ears, in the sense of, we have really, really, really come a long way. If we are having such important conversations at your levels, at the level of research and NGO and government and researchers sitting in the same room and talking about the first 1,000 days, the importance of getting all these services out, of engaging community. These are really important conversations. I hope that there are many more people in this room that will sort of come into this tent, learn very quickly, because we have to move very fast. I think our concerns now are around, it shouldn't take us another 10 years. It shouldn't even take us another 5 years to get where we want to get. So we want to move these conversations really fast, really far, really wide, and making them happen either at the community level or the policy level or everywhere, to take nutrition to all. So thank you for the opportunity to be with all of you today. We look forward to seeing the magic that you create together.